All right. You guys can still see him?
Yep.
Okay. All right, you got normal view going now. I tried to hide some of the panels. Does it look okay on your end?
Yeah.
All right, cool. All right. So this talk, I put into the mix, I don't know, probably about 5, 6 years ago now, just to try and start rounding out some of the topics that are a little bit more general medicine like, which they will ask you questions about on CAQ, but also for some practical points, because you do come across this stuff for sure in kind of the everyday sports world. So it's not too long. We'll try and rip through it. So we'll talk about anemia as for sure iron deficiency, which is probably like the most practical portion of this talk. Then we'll hit a little bit about sickle cell disease and trait, coagulopathies, and bleeding disorders. So thinking about anemia, there's really like three types of anemia we talk about when we're thinking about the sports world in terms of questions that you'll get, as well as like clinical things you'll run into. So probably the most common is what we consider iron deficiency anemia, or what we treat a lot, iron deficiency non-anemia, which is going to be like those low ferritin people. And then physiologic dilutional anemia, and then exercise-induced hemolysis. So these are all important to think about clinically, especially if you're drawing blood work from your patients. So just a little bit of basic science review, thinking about the labs that we draw. So total body iron contains 60% is in hemoglobin, 30% in ferritin. So you have ferritin, which is an acute phase reactant. So you have to always be a little careful when you're interpreting this number. But the main thing to think about is it's essentially the index of your iron stores. So you're going to use this to look and try and figure out how much does somebody have in storage, and remembering that this can decrease when people start their training or before a season. It's super important to check it. I really like to check people like 3 months before their season starts. Transferrin is what binds your iron. TIBC is your binding capacity for transferrin. So you want to think about this as like how much room do you have for iron to be added? And then transferrin saturation is essentially your serum iron divided by your transferrin times 100. So why do people become iron deficient? First off, blood loss in females from menses. You can have genetic anemia. In combination for women, the thing that tends to get us is the fact that we tend to have low iron intake. Iron is absolutely absorbed the best through food, not through pill form. So I tell everybody if we find they're low with their ferritin or low with their iron, that the first thing they should do is Google a list of iron-rich foods and start incorporating them into your diet, because you absorb them so much better than just popping a pill. So the average diet has about 12 milligrams, and women need about 15 to compensate for their blood loss from menses. And then decreased absorption. So if you have reflux, if you're sitting there like me drinking a cup of coffee, but having your smoothie with spinach in it, you may not be absorbing it as well. So you can have different problems that block the absorption. And that's the other thing. Sometimes if I have somebody on iron and their levels aren't going up, we look for a cause for why aren't they absorbing it, besides just, taking it, the wrong time, or taking it with things they shouldn't be taking it with. Sometimes we'll do a little bit of absorption workup. And then gastric loss. So, marathon runners actually often have occult positive stools. So there can be some mechanical trauma to the gut that happens, and you get blood loss. And so you can actually have gastric loss from of blood. So a lot of times I'll actually work these people up. If their iron's super low and diet doesn't seem to be the reason why, I'll usually have them do some stool guaiacs and run a UA just to check. So why do these people even get worked up? Like, what on earth are you looking for? Why are you drawing blood work in a sports clinic? Well, probably the number one reason, besides patient requesting it, would be trouble with performance and endurance. So we'll see people come in and they'll just complain, especially you'll get this in training room a lot, I think, where people just feel like they're not performing as well as usual. They're tired, their times are off, and it's almost always those heavy running sports. So you're going to get this with your cross country track kids. You're going to get this with your soccer players, sometimes your football players, but really your cross country track and soccer, especially the females. So you always want to put this in the top of your list when you're thinking about people having performance endurance issues. And then weakness and fatigue. And then dyspnea earlier than expected for training level can sometimes be an issue. And then the most common reason I probably draw it is exertional symptoms. So I see anybody with bilateral leg symptoms when they're running and it's really exertional in nature. I'm almost always just drawing blood work and checking what their ferritin level's at. I usually try and keep ferritin around above 30, but I don't even like sending people for compartment pressure testing until their ferritin's like over 20. I really try and get them to correct their iron and see if it fixes their problems. It's pretty amazing how many times you can get it up and then people's symptoms go away. So what do you look for on exam? Well, not much. I mean, there's textbook stuff you can look for, glossitis, and then the nail bed findings, pallor, but it's hard to find things on exam. So I typically go right to blood work. When you're looking at blood work, I'm always doing a standard iron panel. I do a CBC. I usually do it with a diff if I'm looking for reasons for fatigue because I may be getting other labs. So ferritin for sure, CBC, and then my iron panel. And when you're looking at the labs, first thing that you think about is where's my iron? They've said like consider CRP at the same time to rule out an acute phase reactant. And if anybody's been sick recently, I'm always hesitant to overinterpret these labs. But ferritin should be your first marker to go down. So if somebody is working towards being iron deficient, they're going to have what we call iron deficient non-anemia, which I consider just stage 1 of iron deficiency. It's essentially your earliest marker that you're not getting enough iron in your diet or you're losing too much blood or both. Um, Less than 40 will often flag as abnormal. It is really hard to get people over 30 if they're an athlete who runs a lot, I find. So really 30 is my goal for these kids, but on lab work, less than 40 will flag. If anybody's coming in like under 15, they're usually pretty profoundly affected with symptoms, you'll find. Um, I definitely have had in the past, like anybody less than 10, I used to send to hematology to get looked at for IV iron, and we'll talk a little bit about treatment options. Second stage of iron deficiency non-anemia is TIBC bumps up. And then iron can also decrease at the same time, but typically we don't see that hemoglobin dropping till you're stage 3. And then one of the most important things to remember is if you're hitting the point where your hemoglobin's low, you're going to have a hypochromic microcytic anemia. So it's super important to remember which one's microcytic and which ones are not microcytic. So just remember iron deficiency is microcytic. That was probably already pounded into you earlier in your med school education, but it does come up on boards. Oh. So why are we treating anybody with a low iron? With a low ferritin, but not low iron? Well, because we found these people can absolutely be symptomatic. And the theory is that if you have less oxygen available for hemoglobin synthesis, you're going to have less iron aerobic capacity. You can improve your iron stores, which is going to help you transport that oxygen. And then overall, you should have a better chance of improving your VO2 max. So we've really thought about this as helping people potentially with their performance. So another study done in 2018 did a review, 12 studies. They focused more on performance, and athletic performance was unchanged if the ferritin was over 20, but anything under 20 when they supplemented with iron and improved performance. For the people who are like 20 and higher, I'll often put on iron still because you want to prevent them from falling under 20. But for the people under 20, I aggressively supplement them. So how do you treat this? Well, kind of standard old school was, and still probably the most common way is just oral. So there's ferrous sulfate and ferrous gluconate. The gluconate version is better tolerated. They say it has better absorption and it's easier on your stomach. There is some studies showing there's improved absorption with every other day dosing. So twice a day dosing or once a day dosing may not even be as helpful as we used to think it was. So I usually tell people shoot to try and take it at least, 5 to 6 days a week, knowing that people are going to forget some. But I tell them this is not one of the things that you need to take religiously. If you're taking this religiously, you may actually do yourself a disservice. So I tell people shoot to take it about 5 days a week. And then you're looking for anything that has an elemental iron total between 40 and 80. A lot of them are right at like 65. One of the most important things you can tell people is to take it with a tall glass of orange juice that is not calcium fortified, or take it with a secondary vitamin, which is vitamin C. This helps you with absorption. But a lot of people, take their vitamins in the morning, and maybe kids are having a tall glass of milk. That is not going to end well for them if they're taking the iron. There's not much point in it. So it's super important that people know to take it with vitamin C in some form. And then, like I said, I tell them always Google a list of iron-rich foods and start working them into your diet. Just remember, even if somebody is vegan and they're not getting in meat or eggs, they can still get in those dark green leafy vegetables. It's gonna help. And then IV iron, if somebody's less than 10, in the past, I have sent them for a consult to heme to discuss having an IV infusion. The IV infusion corrects people super duper fast, but not all insurances approve it, and there is some risk with it. But if I had a kid get their blood drawn and they were on the brink of starting their competitive season and their iron was less than 10, I would probably strongly consider having them see heme if I could get them in. So here's kind of some of the standard ones you'll see on the market. Slow FE is a nice, easy to swallow one. So if you have kids who are like, I can't swallow those big, nasty pills, Slow FE is a tiny one. That one's not so bad. And then ferrous gluconate, the one on the right, is probably the most common one I put people on. It's easier on your belly than the Slow FE is, can still give people some trouble. So what's new in the iron market? Sucrosomial iron. So this has become much more common to prescribe recently. I actually have Alyssa and Riley are both on this. They both consistently test low with their iron. Riley was one of those stubborn college kids last summer who I kept saying, go get your blood work done, go get your blood work done. And 2 weeks before heading back to school, she had her blood work done and her iron was in the gutter again. So I wasn't very happy with her because we had wasted all summer and we probably could have fixed it. But 2 weeks before soccer season, I think she came back with a ferritin like right around 14. So I sucked it up and got her sucrosomial iron. And I say I sucked it up because it's a huge cost differential. So you buy one of those other bottles of iron and you're talking like a very small kind of standard vitamin investment of maybe like $10 to $12 for the whole month. Sucrosomial iron is about $1 a capsule. So it is much more expensive. If you do the name brand, the Sucrosomial one, I'm sorry, it's actually not $1 a capsule, it's close to $3 a capsule. So one container of these runs about 90 bucks. So for somebody who's trying to get their iron up quickly and you can't do IV, the $90 investment may be worth it for people because you can use your HSA, FSA money on it. So for my kid, she was right before the competitive season. I put her on this, and within 2 months, her iron was almost normalized. So if you can get them up to normal and then switch them over and put them on just ferrous gluconate, sometimes that quick increased expense is worth it for people. So why does sucrosomial iron work better than regular ferrous gluconate or sulfate, it's because it actually has this core which is covered in some special phospholipid, and so it coats it and it has much better bioavailability. It has a much lower side effect profile. There's almost no complaints about people having constipation or belly upset. You can take it with or without food, which is nice for a lot of people, and then it already has vitamin C built in to the iron dosing, so it helps with absorption, but I usually still tell people take it with a glass of orange juice. It's close to the same efficacy as IV iron when people study it, and the reality is even though it's expensive at about $90 a bottle, it's going to be cheaper than getting an IV iron infusion done. It's just going to work a little bit slower. So who do we screen? That's a great question. A lot of times I have anybody in an endurance sport get screened. So ideally, I like to have them get checked 2 to 3 months before their competitive season. And when we were working at Case consistently, we would actually have letters go out, and they probably still do this. All the cross country kids, when they get their paperwork in the start of the summer, requesting them to get their sports physical stuff together, like their sickle cell tests and stuff, we usually tell them, go to your doctor and get your iron labs drawn now. And I do it at Ursuline too. I have a letter go out. Anybody who gets iron labs drawn, I review them. And we usually discuss whether or not I think they should get started on iron. You're never wrong screening these kids ahead. If you can catch them 2 to 3 months before the competitive season, sometimes you can correct them so they don't have performance issues. If you're screening at physicals, you're going to be too late. So you really want to catch these kids early. Premenopausal women should get screened. They say every 5 to 10 years. I would say every 5 at a minimum. And then just make sure pregnant women should be supplemented daily. And then postmenopausal is not as important to screen unless you're a high performance athlete. All right, so that's everything with iron. Does anybody have questions while I chug my coffee, which is going to stop me from absorbing my iron? All right, we will move on. Physiologic dilutional anemia is an interesting concept. This is, I think, the only hematology concept that came up on my CAQ, which I thought was kind of funny that they asked about this, but they want to make sure people can recognize it. So, conditioned athletes get an increase in their plasma volume as an adaptive response. So you will see people have volume expansion, blood viscosity decreases, it improves oxygen delivery because you get increased stroke rate and cardiac output. But as that plasma volume increases, what happens to your hematocrit? It's going to drop, but it's just really tricking you. It's essentially a physiologic dilutional anemia. You're not really anemic, just your plasma volume has increased. So you get plasma volume expansion as a result of large amounts of sweating, activates your RAAS, you get plasma volume retention, and then you actually get an increase in erythropoiesis because it thinks you're running low. So it's actually thought to be advantageous. One of the more important things to remember is um, this is going to end up being a macrocytosis in some people because you're going to have large, young red blood cells in the circulation because you're kicking out new red blood cells often. And your hemoglobin is just going to be a hair lower than usual. So this isn't going to be somebody who's profoundly anemic. It's just going to be one of those people where you look at the labs and you're like, oh, it's a little off. So you may find lower ferritin in runners also as a result of that increased hemolysis like we talked about. There's some mechanical trauma to the red blood cells. But when you find physiologic dilutional anemia, there is absolutely no treatment. You just watch it. The most important thing is you need to recognize it. So you can have that exercise-induced hemolysis, like I've mentioned briefly. It can be seen in non-impact sports as well, but most of the time it's thought to be mechanical, where you're actually having heel strike when you're running ends up causing muscle contraction, and there's some intravascular hemolysis. Most people call it foot strike hemolysis. They also think maybe red blood cells are more fragile in the exercising environment because of increased temperatures and lactic acid buildup. But in the end, you end up with some red blood cell destruction from most commonly impact. So sometimes you'll see questions about this in runners, but a lot of times they talk about marching in the military causing this also. So how do you screen for exercise-induced hemolysis? Typically, you do a UA, and if somebody's positive for hemoglobin, and they have a little bit of macrocytosis and their reticulocyte count is up, which is another good lab to run, you should feel pretty comfortable that's what's going on. Some people will make individuals rest for 4 to 5 days and then repeat labs. If things look good, then it makes you feel a whole lot better. That's kind of what you're dealing with. So when I have those kids who are significantly iron deficient anemic, a lot of times I will have them do a UA. And if I have them do and if they get, and I'll run a reticulocyte count at that time. If they are having positive UAs, sometimes we'll stop exercise and just repeat labs in a couple days and just double check, make sure there's nothing else going on in the kidneys that's accounting for the UA that's positive. Again, what do you do for these people? You increase their dietary intake, you supplement them if you have to, but they're usually not horribly low. You can decrease training intensity. Most people don't want to do that, but the other thing to think about is altering the training environment so that you're having something change from with the training surface. So if somebody's a consistent concrete runner, you may want to think about switching them over to a softer surface. All right, switching gears a little bit. You guys ready for some sickle cell? So this takes you back to probably some med school stuff. Nobody really likes thinking about the physiology of stuff early on a Friday, but we're going to talk a little bit about it. So sickle cell trait occurs when you have two normal alpha chains, one normal beta, and one abnormal beta. And then sickle cell disease results when you get sickling in the deoxygenation, and it can lead to painful crisis, including in sickle cell trait people. So the most important thing to think about is sickle cell trait in the exercising athlete because they love to talk about it, and it's a common cause for exercise-associated collapse. So 6 to 9% of African Americans can be sickle cell trait positive, but this absolutely crosses racial lines. And I always tell people you cannot judge a book by a cover, no matter what color somebody is. They can be sickle cell trait positive. I have had kids probably annually in my clinic who come in who are sickle cell trait positive, who are not African American. So you have to remember everybody should be tested when they are headed to college, and we'll talk a little bit about that. And for people who are outside of the college sports environment, you have to remember that sickle cell trait can be a cause of collapse in anybody. So if you're covering a marathon and you see somebody collapse, regardless of their color, it's something that needs to cross your mind. Uh, Sickle cell trait routinely does not affect exercise capacity until you're under extreme stress. So, luckily, we don't run marathons in altitude in Cleveland, but we certainly get dehydrated people, and we absolutely can have days with extreme heat when we have the marathon and people running at extreme intensity. So, you're going to think about this more in high altitude places, but there's absolutely conditions with high heat, high intensity, which can cause problems for sickle cell trait. Hold on one sec. My little one's up. Hey, Emmy, there's breakfast sitting on the counter. Just pour your milk. Nobody has school today because nobody actually goes to school anymore in Cleveland. All right, now my slides are not working. There we go. All right. In terms of sickle cell trait complications, like I said, it's associated with exertional collapse and sudden death. It results in rhabdomyolysis. So when these people collapse and they're having extreme pain in their extremities, that is something that should cross your mind right away. They can have exertional heat stroke, and then exertional death is most likely to happen early in the season in somebody who's poorly conditioned or is under high heat or in high altitude. So that's what you want to think about. There was actually I can't remember if anybody's a Steelers fan, maybe they know, but there was a Steelers player who was sickle cell trait positive, and they went to Denver to play a game at altitude, and they actually had an event with their sickle cell trait causing rhabdo. So that player no longer played whenever they went to Denver. So it's super important to think about if you are in an area playing with altitude or you land practicing in an area with altitude, this needs to be much higher on your list. So exertional sickling leads to sudden onset muscular symptoms. Um, they tend to have normal mentation, so they're acting normal as opposed to people who have exertional heat illness or heat stroke. So they tend to be acting normal but have extreme muscular pain. They're going to have that normal temp. But if they're having exertional sickling, you've got to remember this can lead to sudden death. So you got to get ready to resuscitate these people right away. Why do they get rhabdo? Because that exercise causes deoxygenation, and then you get sickling, and then you're essentially having vasoocclusion in your working muscles. So anytime you see like a sudden drop, you want to think about this, or somebody grabbing at their muscles. They can end up with muscle necrosis, elevated CKs and myoglobinuria, and renal failure. And it can be related to that exercise intensity with that lack of break. So people undergoing testing, like military testing or police academy, fire academy testing. But really, this is your early season athlete who may be having a fitness test in hot weather. It's important to recognize if somebody's struggling. If you see somebody and they pull themselves out and they think it's just kind of standard cramping, you always want to think about this because it's going to present a lot like cramping in the beginning. But if you see somebody really struggling, you need to pull them out, lay them down, get them oxygen as soon as you can, and check their vitals and hydrate them, and then consider it a medical emergency. So the NCAA began screening for in 2010, and they used to be really pretty easygoing about it. And as long as you had a copy of your newborn screen, because a lot of states test people, you could submit your copy of your newborn screen, and you were off the hook. Starting in 2025, they actually changed the requirements. So you have to turn in a copy of a recent hemoglobin solubility test. I'm not sure why they changed the rule. The hemoglobin solubility test is not an expensive test, but it does require people to have access to healthcare in order to get that done. Mm. So now people actually have to show up and have a test um, within the last year to turn in, and they will no longer accept newborn screens. So how do you prevent sickle cell trait? People from having problems. The most important thing is to acclimate them for heat and altitude. You want to avoid dehydration and overexertion and have a gradual progression. So whenever I have one of these kids on one of the sports teams, or if I'm doing a physical on them and they know they're sickle cell trait positive, I always write on the bottom of their physical, no timed trial or conditioning tests in the first 2 weeks of practice. And then I write they're required to have extra water breaks and breaks in the shade. Um, because these are people who you don't want to get overheated or overexerted. And if you give them 2 weeks before they're doing a lot of conditioning tests, you're preventing them from having issues with acclimating in the weather. So a lot of people, especially at the college level, they may live in Ohio, but they may show up to Texas, and the heat conditions are just not the same. So it's important to allow them time to acclimate. Right. Anything else on sickle cell? Those are honestly probably the main things you'll get asked about and be forced to recognize on CAQ. And then this stuff is thrown in for a little gravy just to round out hematology. So thalassemia has alpha and beta types. Occasionally, I will run into a kid who is sickle thal. That's the other thing you can have is you can have those funky combinations. If you're thal trait positive, you're asymptomatic. Probably the most important reason to know about this is because it can confuse you when you're drawing blood, because thalassemia has come across as being microcytic. So it's important to remember if you have somebody who's consistently microcytic and you're having trouble interpreting their iron lab work, you can always check for thalassemia. There is no contraindication for sports participation. Coagulopathies are something to think about in the sports world. Probably the most common thing we see is people who are factor V Leiden. You can be homozygous or heterozygous, and you can have protein C and S deficiencies or antithrombin mutations. So you really want to think about this if you're having anybody who's coming in and you're like, geez, do they have a blood clot? So those patients who you've either immobilized for a prolonged amount of time and you're worried because they're having pain in a lower extremity, or if somebody's just presenting and they have unusual leg pain, that's not adding up. You want to think about these, especially if they have risk factors. So one would be a family history. So if anybody who they're directly related to has had a clot, you always try and find out. Most of the time, people are worked up for these issues, but not always. So if there's a strong family history of clotting, and then you always want to work somebody up if they have a clot, but that's really hematology's job. And then thinking about what puts people at risk for clotting. So in our world, it's going to be prolonged immobilization. Trauma can sometimes be a little bit of a risk factor. And then people who just had a long trip. So anybody who's been flying, been in the car a long time, anybody who is on um, oral contraceptives. So if they're on any hormones of any sort, they're a female, you want to for sure think about that. Pregnancy is a risk factor. And then anybody uh, who has cancer, that's the other thing. So that one we don't see very much. So factor V Leiden mutation is fairly common though. So these are things you do not want to ignore. So rule for testing is really up to the hematologist, and it's not something we do. And these people don't get tested at the time of their clot. They get tested after the fact as a follow-up. So bleeding disorders is another one you want to think about. There's multiple types of von Willebrand's. My own kid has von Willebrand's type 1. She got worked up this past year. So when you're seeing people who are getting significant size hematomas. They're bruising easily. You always want to start screening them and asking questions. So things to think about in females would be heavier periods, but in kids who are younger or in both genders, you want to ask about mucosal bleeding. Like when you lose teeth, do you bleed a lot? Do you get frequent nosebleeds? When you cut, do you bleed a prolonged amount of time? It tends to be that mucosal bleeding, which can trigger people. My own little one was a very, very, very frequent bruiser, like to the point where I think on day one of kindergarten, I had to talk to the kindergarten teacher and explain to her that the forearm bruising pattern where it looked like I had gripped her was indeed a normal type of bruise for her. And she's just always bruised easily. And then she had a fall on her knee last year, which caused a significant hematoma. And then I worked her up. Um, the interesting thing with this is you're pretty much taught that non-contact sports are okay. And then you go to the hematologist and they're like, oh, yeah, they can do whatever you want. It doesn't matter. So I was under the impression that she'd have some restrictions on her, and they seem to not care. But there are multiple types of von Willebrands, and some are more severe than others. So if you see somebody who's frequently bruising or anybody who presents with an abnormal hematoma for the amount of trauma they had, you may want to think about getting them worked up. And then these obviously will present much more rarely to us. But if you do have a young kid who presents with joint hemarthrosis, you may want to at least think about these people if they had no trauma. So it is important to think about having heme involved. All right, who's awake enough for questions? You guys ready? Which of the following is not true regarding iron deficiency anemia in athletes? A. Women are at a higher risk of developing iron deficiency than men. B. In the initial stage of iron deficiency, serum ferritin concentrations are low, while ferritin and hemoglobin levels are normal. C. Foot strike hemolysis is a known cause of iron deficiency anemia. And D. Inadequate caloric intake and menstrual losses are common causes in female athletes.
B.
B. Yeah. See, I didn't make these too hard. I was nice. What? Yeah. All right, next question. 22-year-old vegetarian female runner presents with increasing fatigue over the past 3 to 4 months. She denies changes in her exercise routine, but has noted that her times have increased over that period and her recovery times have increased as well. So she's got some fatigue. She's got some pale conjunctiva. Her lab studies reveal a microcytic hypochromic anemia. So we know she's got multiple reasons to be anemic, right? So we have a vegetarian, we have a female, she's getting fatigued. Her lab studies reveal a microcytic hypochromic anemia. Which of the following is the most likely underlying etiology for the anemia? Foot strike, vitamin B12, folate, iron deficiency, or G6PD deficiency?
I
Iron
don't
deficiency.
know.
Yep. So you're going to still have iron deficiency. You have to remember that B12 and folate are going to give you a macrocytic anemia. And then the foot strike hemolysis rarely causes symptoms that are going to be this significant. So this is a classic history for somebody who's a menstruating female, especially if they're vegetarian, but you don't have to be vegetarian in order for this to happen. Like I said, B12 and folate are going to be macrocytic. Foot strike is much less likely to cause extreme symptoms with that performance. And then G6PD is a hemolytic anemia, so that one's going to be normocytic, normochromic. Which of the following statements is true regarding a patient with a bleeding disorder? So a history of ecchymosis after trauma is suggestive of a bleeding disorder. A history of epistaxis, especially at high altitudes, is suggestive of a bleeding disorder. The most common form of bleeding disorder that causes MSK problems is factor 10. ACL construction should be avoided in ACL deficient patients with bleeding disorders because of risk of post-op bleeding, or hemarthrosis can result in advanced degenerative changes of joints even in young patients.
A mouthful.
I know, especially when you haven't had your whole cup of coffee yet. Anybody?
Go with E.
Yeah, it's E. So that's really why you want to identify hemarthrosis. So if you have a young patient who presents with hemarthrosis, and they don't have any known trauma, like those people absolutely need to get worked up for a bleeding problem that's more serious. Which of the following statements is true regarding sickle cell trait and sickle cell disease? A, individuals with sickle cell trait have a decreased exercise capacity. B, individuals with sickle cell trait are not in increased risk of sickle cell disease in the absence of other health problems. C, presence of hemoglobin F on electrophoresis is pathognomonic of having sickle cell disease. Or D, individuals from many ethnic backgrounds may have sickle cell trait. Come on, this one's a softball one, people. Which one's true?
D.
Yeah, so pretty much anybody can. So just remember, hemoglobin F makes up the main component in fetal life. It's found in variable amounts in most people, although it's higher in sickle cell disease. So it can be common in West African individuals, but also South American, Caribbean, Central American, Middle East, and India. So just remember, color does not determine sickle cell status. Think about anybody can have it, especially if you're on the sidelines and somebody has a collapse. Don't eliminate it from your differential. All right, and there's my 3 children a little while ago, about 2 years ago. Questions at all? No questions? Everybody's wide awake, hopefully. So this should get you starting to think a little bit about kind of some of those general medical issues that you'll one, deal with in practice, but two, also deal with for CEQ. Um, so you guys are welcome to tackle any of these other subjects when it comes time for coming up with your own lecture. We'll have each of you guys prepare a lecture in May to give on a Friday. So you may want to think about what topic you're interested in. I do have the schedule done for the remainder of the year. So if there's a topic that you're thinking about giving, make sure you reach out to me and I'll let you know whether or not somebody else is already scheduled for it. But a lot of the general medical ones are good topics for folks to give. And for those of you who've not taken your ITE, please take your in-training service exam before your window of opportunity runs out. It really helps us kind of know where you are in terms of your education at this point, and if we need to give you any recommendations for supplementing your education. And then when you get your score, just forward it to me. In the past, 62 has been the score that AMSSM reports is predictive of people passing their CAQ as long as you stay on target. So if you get a score in the 60s, do not freak out. That's one of those things that we expect. So once you take your test, though, send it over to me. Okay, everybody good?